Welcome to our Research Connect series. My name is Nick Murphy. I'm a postdoc in bioethics at Western University, and more importantly, a CDTRP trainee. I have been since 2020. I'm going to be facilitating today's webinar. First, I'd like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. I'm speaking to you from Western University, which is located on the traditional lands of the Anishinaabe, Haudenosaunee, Lenapehoik, and Chinungkton nations. And I encourage you to write your land acknowledgement in the chat box. We'd also like to acknowledge Asteas, Takeda, and AstraZeneca, without whose generous support we could not host these sessions. The CDTRP also relies on the help of our community, and your gifts ensure that we can focus on delivering our mission of supporting excellence in donation and transplantation research. And there's going to be a link in the chat box for those who are interested. Before we get into the main content, I'm going to pass it over to Erica for some general CDTRP updates.
Thank you. I have two save the date announcements today. The first is for our PFD forum. This year's Patient, Family, and Donor Research Forum will be held virtually on June 8th and 9th. Registration is free and can be done through our website. The link to register will be shared in the chat, and I recommend that you do check out that link because if you scroll down, you're going to find the framework for our excellent program. The second point is for our annual scientific meeting. This year's ASM will be held in a hybrid format with the in-person component in Montreal, Quebec on December 5th and 7th. We're delighted to announce that this year's co-chairs are Dr. Siba Hakel and Vanessa Silva A. Silva. We are currently accepting program submissions for session ideas. So if you have an upcoming project that you want to discuss, maybe an idea for a collaborative project that you want to recruit PIs, trainees, or PFDs, a workshop idea, interesting idea for debate, something we haven't thought about yet, submit your ideas. Speaking of submitting, this year we are also having an oral competition for trainees. Winners of each of the 5 themes will receive $150 as well as free registration. Finally, this year the education platform will host a pre-peer review workshop to help trainees and researchers perfect their manuscript before publication. All the information of what I just said will be, all information including the submission links of what I just said will be found on our website, and I'll put the links in the chat box. That's it for me, back to you.
Thanks. So before I introduce the speakers, I just have a couple of housekeeping notes. Today's session is being recorded and it's going to be posted on the CDTRP website and YouTube channel. During the presentation, we encourage you to keep your cameras on, but we kindly ask that you turn your mics off. And if you have a question or comment, you can raise your hand with the raise hand button. So it's my pleasure to introduce our presenters, Dr. Matthew Weiss and Dr. Claire Williment. Dr. Matthew Weiss is a pediatric intensivist working in Quebec City at the Centre Hospitalier Universitaire de Québec and an assistant clinical professor of pediatrics at the Université Laval. He has multiple provincial and national donation roles, most notably as medical director of donation and transplant at, donation at Transplant Quebec. His research interests mainly focus on implementing legislative and policy reform in organ donation, and he's the national lead of the LEADER research program, which focuses on implementing reforms in Nova Scotia. He has led or collaborated in developing several deceased donation best practice guidelines, and his many peer-reviewed publications touch on diverse aspects of adult and pediatric donation. Ms. Claire Williment was appointed Chief of Staff in NHS Blood and Transplant in January 2023. Prior to that, she led the opt-out legislation implementation and organ utilization programs as the accountable executive for the UK. She was responsible for developing and implementing plans to make changes resulting from alterations to donation consent legislation in the UK, while leading an integrated portfolio of activities designed to maximize organ transplantation in the country. She was also appointed as the lead secretariat for work on behalf of the Department of Health and Social Care to deliver recommendations for improving organ utilization, equity of access, and resilience of the transplant care pathway and driving innovation. Before joining the NHS blood and transplant, Claire worked in the Department of Health as a senior policy lead with organ donation, respiratory disease, and pathology services within her portfolio. She also spent several years working in health ministers' offices. So we're all very excited to have the speakers here today, and I'll hand it over to you guys.
And Claire, I think we said you would you'd go first, right?
Yep. Do I pull up my slides?
Perfect.
Cool. Right. Share screen. No pressure. It
I
won't
can share. I can share for
Yeah,
you,
thank
Claire,
you.
if you
So
want.
we'll just
Yeah.
do that awful next slide, please. Clicking thing. Just whilst it's coming up. I'd just like to say thank you very much for the opportunity to come and speak today. It's very much appreciated, and it was a real pleasure and privilege working with a lot of colleagues on the Legislative and Policy Forum. So I just like to take a short while to talk through what we did, why we did it, how we did it, and what the outcomes were. So if you could click on the next slide, please. I don't know if it's showing the next slide for anyone else. Have I gone silent?
No, it's still on the intro slide.
This.
Okay, I'll carry on talking whilst whilst we're waiting for the next slides to. Okay, there we go. Yeah. Before I move into the presentation, I'd just like to acknowledge my colleagues that were in my drafting group that you can see named there. You can see that we were spread across the world, so it was really great having all those different contributions, and there were people that were involved in organ donation and delivery of services, as well as caregivers and a donor family member as well. So it was a very multidisciplinary group. Is it possible to press the present button rather than share it that way, just so because there's animation? It doesn't matter if not. Maybe not. Down at the bottom.
It's coming, no worries.
It's coming. Okay, great. So thank you very much. The remit was of our group was particularly to provide expert guidance on the structure and function of organ tissue donation and transplantation, so OTD systems, inform those working within OTD systems to either establish new ones where none exist at the moment, or to improve existing systems. So what we were trying to do is really provide the building blocks to what is a good, effective organ donation infrastructure and system. And the idea is that people could pick out different ones of the blocks, if you see what I mean, or add on to the blocks that they already have. And as I just mentioned, we had a range of experts on the group. We also had, in terms of what we did, stakeholder engagement exercises. We did literature reviews. We had a scientific committee review, and we also worked to get consensus amongst us as a group. If you click next, please. Thank you. So in terms of our chapter, we followed the care pathway that you can see laid out here. And I'll talk you through some of them, but I won't talk through in a lot of detail of every single one. I would strongly recommend you go in and have a look at the chapter. It's absolutely excellent. So we followed the care pathway, and for each one we provided a theme, a recommendation, and what were the markers of best practice within that recommendation. So how would you know that that recommendation is being implemented effectively? We focused on the systems of architecture and infrastructure rather than what's best clinical practice. So if you click on the next slide, please. So our first one was supporting infrastructure. You can see there a series of recommendations. If you click again, please. And those were the markers of best practice within the supporting infrastructure. I'm not going to talk you through every single one, but I will pull out just a couple. So if you click, please. So clear roles, pathways and accountabilities. I'm going to mention it here because it's a particular theme that comes up again and again and again. So that is really vital throughout the care pathway. It needs to be really, really clear who does what, when and why, and who's accountable for that action. Is really important along the whole system, as is that openness and transparency. It's important so that everybody's clear what everybody's doing, but also it maintains clinical confidence, but also public confidence, which is so important in organ donation and transplantation. If you click again. Research and innovation, again, it's important along the care pathway. You can't do enough, and it's not just the big research programs. It's that innovation in actually sometimes quite small changes can make huge and significant differences. So it's not just the big research programs. Yep, sorry, click again. So to start off with the first stage of the care pathway, those were the ones under the infrastructure. So to move on to the education part of the care pathway, which is both the public and healthcare professionals. If you click again, please. Those are the series of recommendations. And if you click again, and again. So effective governance, again, it's a theme that runs across, but it is really very, very important in terms of the effectiveness of the organ donation and infrastructure. And an organ donor registry. So in the UK, it's a very, very powerful tool. We know that our consent rates, if somebody signed onto the organ donor register, our consent rates are around 90%. If somebody's not recorded a decision on the organ donor register, then actually the consent rates from the family are around 60%. So it's a really important tool for the UK. But having said that, it takes a lot of time and effort to establish, and not all countries are able to do that. So for us, it works, but it's not absolutely essential, but it does enable the public to record their decisions. If you click again, the campaigns to encourage the public to consider and record their decision are incredibly powerful. So in the UK, we moved to an opt-out basis for organ donation recently, but we've still kept the organ donor register, and our messages is still, it's your decision. Use the organ donor register, record your decision because it's your choice. And that is a very, very powerful message. And it's not just make their decision, record it in some way and speak to the family about it as well. If you click again. Thank you. The next stage along, detection, declaration of death and referral. Click again, please. And again. So in terms of the recommendations I'm going to pull out here, establish a potential donor audit. Again, it's been so powerful in our experience. It informs every single thing that we do when we're trying to look at improvements, because it shows you exactly where you are missing opportunities along the organ donation care pathway. Again, it takes time and resources to deliver, but is important. No, yeah, that's fine, click. And in terms of the markers of best practice, it's important to have agreed, routine, timely notification triggers, and that word timely is used advisedly. So it has to be a notification at the right time, and I'll come on to that in a bit more detail later on. And the legal and clinical frameworks for the determination of death are really important to gain, again, that clinical and public confidence that what you're doing is not only clinically safe, but legally and ethically safe as well. Of course, there are different sections in the chapters that will cover that as well in more detail, but those frameworks are vitally important. And again, we're a real turning point in the UK, particularly for DCD donation. If you click again, please. So potential for donor evaluation, if you click again. And again, yeah. So in terms of this, that collaboration between critical care, donation and transplantation teams, you'll have seen that collaboration a few slides before, and you'll see them. It's a continued theme as we move along through the chapter. That collaboration, everybody working together. You need clear roles and potentially clear blue space between some different teams, but you still all need to work very closely together. And if you click again, family approach and authorization. And again, yeah. So the family approach should always be made by someone with the relevant training and skills. And in our drafting group, who that person was varied between the different countries. In the UK, we have specialist nurses for organ donation that are very highly trained. They're embedded in hospitals, and those are always the ones that make the approach. I say always, very nearly always. Sometimes that doesn't quite work out. Maybe the family raise it by themselves. Maybe a clinician might raise it. But we found that when our specialist nurses are involved, the consent rates are much higher than if they're not involved in that discussion. And that doesn't mean it has to be a nurse, but it has to be somebody with that training and the skills in having those very difficult donation conversations. If you click again, please. And this need to give the family time and the information that they need to reach a decision is again something that came across from all of the different people we consulted, and particularly from the caregivers and donor family representatives. It's sometimes pressured time, but you need to give as much time and information as you can for them to reach a decision that's right. If you move on again. If we move into clinical management. Thank you. I can't stress this enough, 24/7 access to guidance and advice and the resources in order to do that effective management. And I know that that's not easy. There's the concern that, you know, it takes up beds, it takes up time, it takes up resources, but actually, and it's difficult. One of our doctors described it as, you know, you're doing something that you may not see the benefit of. It's helping patients, but it may not be helping patients that are in the bed in front of you. And that's where some of the pressures come on. But that's where the collaboration and the communication comes in that I touched on earlier, about making it clear how everybody has a role to play, and those resources that need to be you know, secured through the management quite often is so important, and we need to bring those on board. If you click again, please. Matching and allocation. Click again. So in terms of how you match and allocate organs, you can see there again the clear rules and guidance and timely access to resources and so on. But what I'd particularly like to draw out here is that allocation systems provide safety and also the equity of the allocation system. So it needs to be fair. And that again takes a lot of time and resources. And for us, and well, indeed, everybody else that is on the group, it should be the organ donor organisations that are responsible for the offering and allocation, because that would remove any actual or perceived bias in the system. So it's not that you're a clinician and you're allocating to your favourite patient. If it's the organ donor organisation, it provides that impartiality and is based on need and need rather than any perceived or actual bias. If you move on, please. Recovery, transport and preservation. Thank you. Again, you can see that access, 24/7 access to resources, but here I particularly like to pull out machine perfusion to improve organ quality and recipient outcomes. It's one of the large things across the world at the moment, the access to machine perfusion. I think you're quite lucky in Canada and compared to a lot of other countries in terms of what you have access to, but it's one of the ways that you can really maximize the potential for organ transplantation and also relieve some of the pressures on the system. So you can place an organ on a machine and it can stay there for a while you wait for a theatre to become available, or a bed to become available, or a team to become available. It's very, very important. It's something that, like I say, across the world, we're all pushing for. And if you click again, to move on to transplantation, and again, establish living donation programs. It's going to be difficult to ever remove your transplant waiting list. We will never really meet the full demand that there is, but the only way you can maximize the potential is you need living donation programs as well as deceased donation programs in order to maximize the potential benefit, and those are very, very important. If you click again. Innovation, I touched on it earlier with the machine perfusion. That is part of the innovation to maximize the potential for all successful outcomes for patients on the transplant waiting list. but we all need to look to what's going to happen in the future. Machine perfusion is getting there, but we need to make sure that we continue to innovate for future maximization, and we're all watching what's happening with xenotransplantation, for example, very closely. If you move on again, case follow-up, and again, and again, and yeah. So again, I've talked about that communication, but again, the communication between donor families and recipients and how that's effectively managed is really important. And we know that it's one of the most powerful things that the donor family has is those communication from the recipients. But it needs to be done in a careful, managed way to make sure that it's done in a timely way, not at the acute bereavement stage, and that it will be welcomed by both parties. And the chapter talks about that in more detail. If you click again. And again, I can't stress how important this is. The concept of donation being a gift that is freely given, not something that's coerced. And particularly as in the UK, we moved towards opt-out legislation, it became a recurrent issue that was raised that this isn't removing any concept of organ donation being a gift that is freely given. It remains an individual choice and something that is one of the most precious and final gifts anyone can give. If you click again. So if you just keep clicking, click a few times. Yeah, good. So the founding principles, I've talked about them quite a lot, that close collaboration and cooperation across multiple teams, with at every single stage it being very, very clear who does what, when, why, and how. That timely access to resources and information, and here I mean it in the broadest sense, that's resources in terms of the beds and the theatres and the staff to run the processes and the information, but it's also the resources for the families that is ongoing, the information that you give to both clinicians in terms of the how, but also to the families to give them, and the public to enable them to make effective decisions. The clinical, legal and ethical guidance that supports consistent best practice along the care pathway, and that clarity and transparency, again, along the care pathway to support the clinical and public confidence in the system. That was a really quick run through what was a lot of work and a lot more recommendations and details. So please do go in, have a look at the chapters, and hopefully they will help you as you do your work and engage. But if you have any questions, my email is down at the bottom and I would love to hear from you. Thank you.
Great job, Claire. Great. I'm going to start sharing my screen. I can say that having participated under Claire's leadership with Libet with that group, you know, it was definitely the goal was to create a document that we could give to somebody who wasn't necessarily an expert in the donation and transplant system and say, this is what an ODO does. And I think really, as you just outlined, you did that well. Oh, sorry I didn't change the title, the subtitle there. But so yeah, it's my turn. I'm going to be talking about also, obviously, from the same forum, the domain that was touching on consent model. And I'll say a few words at the end about emerging legal issues. Although we can leave that as a discussion as well, because frankly, we didn't really make any recommendations on that. So I just want to, you know, keep expectations low despite the title. I will say we're proud to say, as you saw from Claire's presentation, that the ODO architecture manuscript has been published, but so have almost all of the other domain manuscripts. They were grouped into this issue of Transplantation Direct, which we thought was a great way to get these out, considering the global focus and the capacity for Transplantation Direct to have as an open access platform. So any ODO or transplant focused professionals that were hoping to reform their system in a developing country wouldn't have to worry about paying for the access. So there they all are, with the exception of the Living Donation Group. Anybody that's on the call from that group, I hope you feel adequate amounts of pressure to get that one out. Yeah, but it will be coming shortly. You know, you guys have seen this slide several times, just the various intersections that come together for a donation to happen, starting with a potential donor matched with an appropriate recipient, There have to be Transplant Quebec or another ODO that comes in and organizes the sharing of information between those two hospitals and care teams where they are. You have to have the professionals both in the remote site where the receiver is going to be located and where the donor is. There has to be a lot of logistics to make sure those people can be in the same place at the same time with the resources that are available. And overlaying all of this are the laws and the policies that govern transplantation. So you can see the multiple intersections. And also, another way that I've been thinking about this more lately, the multiple links and chains that have to come together for a donation to happen. And then when they do, you get the single event of one donor giving one organ to one recipient, which happens about 150,000 times a year worldwide. But the reason I wanted to keep those slides in here is just as a reminder that the process for that to happen for an individual donor with an individual recipient, it's true that consent is a necessary part of that chain. Without having consent from the donor, the chain is broken. But it is far from the only factor. You can have consent from a family, but if you don't have timely access to an operating room with an available surgeon, well, the delays might be so long that the family ends up withdrawing their consent. For example, that's one problem among many that can happen. This is from one of the other domains, the legal foundations. And I just wanted to include a couple of their points in the sense that they called for a unified donation and transplantation law. It's certainly the case in Quebec, and we're not unique. This happens a lot of places around the world, where as the system has developed, the laws and the policies that impact the donation and transplantation system are kind of sprinkled throughout the healthcare legislation in various places, various organizations that are going to be have oversight over aspects of the system, and certainly having a consent model that is integrated into a unified donation and transplantation law makes a lot of sense, because then all of your system is coherent. And is based on a unified set of principles. And the law that governs donation transplantation, well, it must be integrated into the existing legal system. The legal group that included a lot of lawyers, including Jennifer Chandler, who I know was on the call, Thaddeus Pope, Megan Taves led it. They really did a good job of reminding people like me, who are more on the clinical administrative side, that while it makes sense to a clinician that you would sometimes want to allocate a particular organ to a receiver based on their age, because you want to make sure that that organ is going to have the maximum positive impact over the course of the organ's functional lifetime. Well, doing so might run afoul of non-discrimination laws that explicitly prohibit age discrimination within the healthcare system. And so it's not to say that that is impossible to do, but you need to make sure that those human rights concerns need to be considered when you are creating a law. So same would go for anything related to a consent model. The question often comes up sometimes, and I should have defined this maybe earlier, is what is a consent model? Well, the consent model is how the organ tissue donation and transplant system confirms consent for organ recovery after death. Now, this is unusual compared to just about any other healthcare setting. Some of you might have heard me say this before, but I can't here today sign a registry that says, in case I ever have severe belly pain and a fever and an ultrasound finding consistent with appendicitis, even if I'm unconscious, 5 to 6 years from now, when that happens, go ahead and take me to the OR. You don't have to ask my family. You don't have to ask anybody. Just go ahead and do it. That's not a kind of consent that would be valid for any other healthcare procedure. Now, the fact that organ recovery happens after death creates a lot of issues around consent versus authorization that people like Nick or that Jen could talk about at length. But it also and the fact that in almost all situations, obviously exceptions for donation after MAID or in a conscious competent donor, but in almost all clinical situations where donation is possible, the person who is the potential donor at the time is not able to affirm their consent. which is a lot of the motivation for creating donation registries, where consent is given ahead of time for a procedure for which you may or may not be evaluated for which you may or may not become a potential donor at the time of your death. And so just to keep in mind that it is an unusual way to consent for something, and is much more akin to laws that are around, say, what happens in a will and testament and what happens to property after your death than what would be typical for a healthcare setting. When we talk about a consent model, normally we're talking about what is often referred to as presumed consent. In the UK and Nova Scotia, they talk about deemed consent, sometimes referred to as opt-out consent. And that is versus explicit consent or opt-in consent. Everywhere now, obviously, these two systems in a presumed consent model, most or all of the population of the normally adult population in almost every system, children are excluded from a presumed consent, but where they are assumed to be to have consented for organ donation unless they have registered otherwise, versus an explicit model where they are assumed not to have consented for donation unless they or their surrogates explicitly say otherwise. So even though it's often referred to as presumed consent, the thing that you need to remember, as I just presented, is that all these systems have presumptions. Even in an explicit consent model, there is a presumption of no that needs to be that would need to be affirmed or overturned by getting consent from the family. So there is no system that doesn't have a baseline assumption built into it, even though deemed consent is often referred to as presumed consent. It's presumed affirmative consent, as opposed to presumed refusal, which is kind of the baseline of an explicit model. You know, and there are different kinds of presumed consent. There's the soft models versus the hard models. You know, what Claire described is being instituted in the UK clearly would be referred to by most people as a soft model, meaning the family is still going to be approached. And I have forgotten the details in the UK, although I know in Nova Scotia that even if the patient had registered a yes in the registry, but the family were to refuse donation, I know in Nova Scotia they would respect the family refusal. That is in the law. I see Claire nodding. That sounds like the same in the UK. Versus various forms of hard presumed consent. You can think of France and you can think of Austria, where they've had various waves where they've strengthened that, and where they either don't approach the family if there is a yes registered, or don't approach the family even if there's a presumed consent situation where the patient had not registered something. Although speaking with clinicians, I think there remains to be a significant gap between what is written in the law in those situations and what is actually practiced at the bedside. But so, for example, in France, well, on paper, you would need to have notarized attestations from two different individuals saying, we know this person would want to donate. In reality, it's not often the case. You know, as Claire mentioned during her presentation, our domain as well, we looked at a lot of literature. This is just one example of the things that we saw that suggests there is really no definitive evidence that your consent model alone is going to change your donation and transplantation activity. There is, I would say, the evidence that has been published in, say, both the medical literature as well as the health economics literature, a lot published in ethical journals as well. The evidence, the kind of hard evidence, the quantitative evidence, is both limited and somewhat contradictory. There are studies that do show a positive impact between presumed consent and increased activity, but a lot that do not. And so there's no definitive answer there in the literature. There have been a lot of publications like these from people that we know, Rafael and Beatriz from Spain, targeting whether or not it is effective. There are other ethical debates that say, you know, as you can see here, if whether or not presumed consent reduces the aspect of the gift aspect of donation, ethical problems with proposed consumed consent legislation. You can see this is something, these are just a small smattering of the articles that you can find. A lot of people have published a lot on various aspects. These are numbers closer to Claire's heart, the UK experience after Wales, which was the first obvious country within the UK to go to a deemed consent model. And you can see that it took some time. The x-axis on this, I forget exactly what the time is, but it took 3 or 4 years before there was a statistically significant change in the consent rates. But you can see once it did, I don't know if you can see my mouse there, but there was a significant difference between England and Scotland, who were still working on an explicit consent model at the time. Curiously, it was a bigger impact on donation after neurologically determined death versus circulatory determined death. But that I think is also that gap is closing, and I believe the tendency is to see an increased consent even in the death determined by circulatory criteria. So this, as you can see, and this she shows the consent rate moving up into the zone where the consent rate was higher in the deemed consent model. And I think that is one of the themes that our group, the domain group, picked up on, is that there is a distinction between what I would describe as a mature system who is implementing deemed consent versus a developing system, such as what happened, say, in Brazil and some other countries in South America when they implemented presumed consent without a robust other aspects of their system. So a mature system, as Claire mentioned, mandatory referral and the potential to verify that mandatory referral is happening through potential donor audits and adequate donation resources all across the board, so that when you get that consent, you can get the patients to the OR in a timely manner, for example. Those are all aspects of a mature system that likely is going to see an impact of deemed consent in a positive sense, more so than a system that is not. And that really leads to our main recommendations. So we did not come down with a universal recommendation that one consent model is superior to the other, basically because both the experience of the group members, as well as the vast amount of literature that's been published on that, did not show one to be definitively superior to the other. So what you need to do is, what are the prevailing cultures, the prevailing values in the culture of your jurisdiction? So if you live in a Western European country where family and social cohesion is a key core value, and altruism and sharing within the community is a key core value, well, that might be more likely than a country, say, as my home in the US, where, look, we want to make sure that individual choice reigns supreme, and we don't want to presume a choice where somebody is going to take something out of my body and give it to someone else. I might want to do that, but I want to have the choice, and my family have the choice. And you might have one system be inappropriate for a culture versus the other. You got to make sure that your system infrastructure is robust and able to handle it. As I mentioned, you have to have the commitment to support a model. There is a lot of training. If you talk to Phil Walton and Claire about all the amount of training that went into making sure the coordinators knew what this was going to mean, making sure what the bedside clinicians knew what it was going to mean, the SNODs and the CLODs and everybody, making sure that there were a lot of changes, and there was an enormous upfront cost to make sure that the model is going to be supported. And then you have to build and maintain public trust. And that has to be specific to all of the populations served in your jurisdiction. I think just about any place in the world, there are going to be populations within a country or within a province that might be relatively excluded from all of the benefits of society in general and the healthcare system in particular. And those groups need special outreach to understand that if we're going to change the consent model, it is not going to negatively affect their autonomy and their ability to determine what happens to their body after death. The paradox of presumed consent, frankly, is that it is the thing that just about everybody wants. Well, it is inadequate on its own. As I mentioned, it has been shown that if you only do that in a system that otherwise is not ready for it, it's probably not going to change, and it might even decrease public trust in your system. But talking about presumed consent might be necessary when a system is going to overhaul itself, and if you really want to get public attention focused on donation and transplantation, because frankly, when you talk to a journalist, I in my role at Transplant Quebec have never had journalists knocking down my door trying to ask me about mandatory referral. or about, whether or not we have enough coordinators to get access to the OR. They don't care about that. What they want to know is, are we going to do presumed consent? That's essentially the only question that a lot of lay people who have very little contact with the OTDT system want to know about. These are some recent articles from here in Canada about provinces that are considering or will be considering a shift towards deemed or presumed consent. And so I think that anybody who's going to reform their system needs to know what the answer for their jurisdiction is going to be. And to get there, you need to have a broad public consultation and a broad stakeholder consultation. So thank you very much. I haven't even checked the time. Oh, we're doing pretty well. Good. So we got time for questions. And certainly I can talk in more detail about any of those aspects, or we can have questions about Claire's wonderful presentation as well. So back to you, Nick, for questions.
Thank you for those great presentations. It's quite an amazing body of work that you've produced here, and I think it'll be an invaluable resource for jurisdictions looking to reform their systems, and particularly maybe in places like low and middle income countries that have yet to really develop any sort of functioning OTDT system. So congratulations on the work, and thanks for sharing it. Just picking up on that theme, in places where there's really no functioning system, there's resource scarcity, where would you recommend policymakers begin? There's so many things here, and Claire mentioned at the outset, sort of, it's, you can sort of pick and choose what to work on first. Where would you start? Would it be the ethical and legal framework? Would it be educating healthcare providers? And this is a question for either of the speakers.
So shall I start? And then, that's a really good question. And whenever I get asked about, something similar, I kind of duck it and say it's not an either or. There's no point starting up if you haven't got a system that is in line with what your society's values are and culture is, and you need to make sure you need to do that work to make sure that you're aligning yourself. But then you also need the clinical community engaged and involved, and that's in it's not just those in intensive care or in transplantation, it's in the wider system, because you need pathologists, and you need renal physicians, and you need everything else. So I would start, I won't duck out of the question, I would start with that initial communication and information gathering about where are society's values and culture around organ donation, and where's the clinical views, culture around organ donation. And then you can start to build a system that builds on where the concerns are and what people believe in and what people want to achieve. But we've seen in other countries where they've not really potentially done that engagement work, and it's gone poorly to the detriment of all, and will take a long time to recover from. So I think it's that engagement piece is where I would start, and then you have to make some kind of practical inroads around the communication for what you're going to communication to see where everybody is, then some clinical guidance about what you want to do, and then communication again to make sure that it's in line with what people are wanting. That would be my, if I was forced to jump off the fence and make a decision, that's what I would say.
Well, sorry for
Matt may completely disagree though.
Yeah.
No, 100%. I think that the thing that you have to do is have an understanding of your system, and you might have a well-financed, well-resourced system, and it is, that one of the issues you have is around confidentiality laws and sharing of information from hospitals to the ODO, and that really is slowing things down. But you might have another system where that's not even an issue, but you don't have adequate financing. And so it's going to really depend on the state of the system and a broad understanding of the system, because I think, if you talk to small groups, well, they'll have their hobby horse, they'll have their own little issues that they're going to know is what's going to solve the problem. But you really got to make sure, and as we always say at the CDTRP, that we're not just talking among professionals, but we're getting the patient and family donor perspective, the people who are really living with the impact of these decisions that they get made.
Thank you. That's for a very comprehensive answer to a hard question. I'll just remind everyone to please feel free to post questions in the chat, or if you'd like to ask the question yourself, please use the raise hand function and we'll call on you. Thank you. Erica?
Thank you for the presentation. Very interesting. It's a field I know absolutely nothing in, and I didn't know there was all these constraints, if I could say, or problems, or lack of better words. How long has this is a very big undertaking, what you're trying to do here. How long has it taken you to do this?
Let's see. Now
I have a two-part. I'll ask the two parts right away so you can. How long has it taken you to get to here, and how do you see future? Like, what does the future for this project look like?
Right. So great questions. In terms of how long it took, I think our first meetings around this, like late 2019, is where we first started talking about this. And then, obviously there were some COVID slowdowns. We pushed back from, we were initially targeting fall 2020, and then it got pushed back to 2021. A lot of the work had been done by then, but then there was still a lot of writing to happen to get the manuscripts done. And as a multi-jurisdictional project where nobody was getting paid to do any of it, it did take a while for the manuscripts to get polished enough to get published. But so that's kind of the main bulk of the work was over roughly a year, where the groups came together and we went through the consensus building process and reviewed the literature. In terms of what we want to do next is that is going to depend a lot on various jurisdictions. So here in Quebec, the minister has expressed some openness to reconsidering the consent model. And we are very much, what's great is that because we have the forum outputs ready, well, we can go to him and say, look, here are this international consensus with a lot of expertise behind it that can show that, yes, consent model is definitely something you need to look at. But look at all this stuff in Claire's publication that needs to make sure we get that we are resourced to be able to do. Make sure that look at the legal foundations. Make sure that research and innovation is also built into the system to begin with. So really, that's the next steps, is making sure that the policymakers and the people the funders and the regulators understand the depth of the problems and the depth of the work that's been done to it, and really support integrating these recommendations.
If I may just add into that, I was, when Matt was talking, I was obviously paying close attention, Matt, but I was also scrolling through to see who else was here. And I would just like to say, I came in, I think, at just the drafting stage. It was billed to me as I just needed to join a single meeting and it would all be done and dusted. It turned into about 18 months of genuinely a lot of fun, but calls at 10 o'clock at night because we had people in Australia and so on. But while I was scrolling through, I spotted we've not just got Matt, who deserves every credit, and your resilience knows no bounds, and your determination, but also there's Manuel and David and Linda, who are on my drafting team as well, and huge shout out to them for all their support and hard work, and particularly Manuel, who is just, I believe, deserves some kind of special recognition and honor for his tenacity in forcing us to do the drafting. But it was great. It was a really good experience. He got so many people from across the world, all engaged, all doing exactly the same thing. And what Matt just talked about in Canada, I think, is also happening in the UK. How can we take it forwards, and how can we promote it when we're talking internationally, so that other countries can pick it up and learn from it and use it as well?
Thanks, and I'll just second that. I can attest as well to what an incredible experience it was participating in this forum as a trainee, an opportunity to learn from colleagues and mentors from around the world, and I really appreciated it, and it could potentially be used as a model for other projects going forward. Dr. Mainra or Rahul, sorry.
Hi, thanks. And great talk, Claire and Matthew. I'm a transplant nephrologist, so I'm on the transplant side of things, and I'm going to pepper you with some questions on that side because I don't do anything on the donation side. But excellent talk and great work that you guys are doing. I'm curious if we see, or if there's such a thing as a lag where we don't realize the benefit of transplantation in opt-out, opt-in systems for a number of years. And I think both of you sort of mentioned this, that these systems don't really work if your OR is chock-a-block full and you don't have resources to actually transplant those organs. So in some of those jurisdictions, what happens with those kidneys? What have you guys seen? What's in the literature? Do we just end up with a whole bunch of kidneys that are discarded? Do these kidneys get exported to other places? Does it take a number of years before locally they actually realize an improvement in transplantation? What would you say to government that's considering changing their consent practices, at the same time put money into the OR, put money into the transplant side of things?
Yeah. Go ahead, Claire.
No, go for it.
All right, so I mean, I think that's a great question, Raul, and I think that the overall, I don't recall seeing that there were jurisdictions where there were so many excess donors that they started exporting more. I think what happens is actually that in the countries where it doesn't, it's less effective. Essentially, what happens is they realize, oh, we're not getting more donors, and they're not getting more donors because, like I said, there's almost no system. There's no system that's going to have a presumed consent so hard that even if the family is adamantly saying no, they're going to recover anyway. You know, that's really that type of presumed consent is certainly not something that would ever work in a North American context. And like I said, like in France, when they've tried to enforce things like that, it just doesn't happen. And so I think what in a system like you described, where they haven't invested adequately in the transplant resources, well, you get people that would say no for the same reasons they say no today, which is often that, no, we can't do another 4 or 5 days in the ICU waiting for a transplant team to be available. And that happens today in Quebec, unfortunately, and in Ontario and in everywhere, because that's just a reality. And so that's where I think policymakers, you know, the thing that I'll often say is I want to get in front of a legislator who is motivated to make, you know, presumed consent a policy they're proud of, because that person is going to be motivated to give me the resources to make sure that it works, you know, and that's and the transplant programs, the resources to make sure it works. So Claire, I don't know what you think about that in the.
I agree completely. We'll never get to a point where we've got so many donors we could meet the demand on the patient side. That's why we need innovation. We need the next generation along of xenotransplantation or stem cells or regenerative medicines or whatever to solve it. But in the UK, we haven't seen, whilst we've seen significant improvements in consent rates, the number of donors is capped, and the pool of potential donors is decreasing over time. But what we saw with opt-out, well, when we introduced some work in the first instance, you know, sort of a decade or so ago, is our donor numbers did increase, but our transplant capacity didn't increase in line. So we saw more transplants, but the number of transplants resulting from each donor was going down. So I've crossed the bench. I've picked up the transplant side of things, and I'm now looking at organ utilization instead, because we invested so much time and effort in the organ donation, we forgot to look and make sure that the transplant services had the capacity and the resources they needed to make sure that we honoured every single gift of donation where we possibly could, where it was safe to do so. And the part of the benefit of opt-out was exactly as you were just talking about, Matt. We got in front of ministers, and ministers made a commitment not to increase consent rates. They made a commitment to 700 additional transplants per year resulting from opt-out. Now, I said at the time that was a terrible move, because that isn't what consent will do. That isn't what consent legislation will do for you. I'm now really pleased, because now I'm back in the Department of Health all the time saying, right, you know, that 700 transplants, this is the resources that we need in order to deliver it. So it was incredibly powerful tool, and it's one of the benefits of the opt-out legislation. Even if it delivers nothing else, which it is doing, but if it delivers nothing else, that focus on not just donation, but on making sure that there's no point in the donation side if the transplantation can't happen, and has to happen in a safe and equitable way for the country, or for the, you know, for the region that your donation process works in. I could talk about this for a very long time, but I'll stop now.
And Nick, do you mind if I address, I see Sean's question from the chat. With Sean, I think, so for those of you who haven't read it, he's talking about how you get a much higher, a greater than 90% consent rate for people who have signed the registry versus around 60, which is consistent across Canada, and in really many parts of the world. For those who haven't, you're right, Sean, that is, it does suggest the impact of a registry. I will say the one question, because we did review a lot of the registry data as well that's been published. And the one thing that jumped out, though, is that it's hard to know what the counterfactual is. And what I mean by that is, if someone has taken the time to register a yes in the registry, well, it's very likely that they come from a family that would have supported donation as well, and they might have expressed that feeling. And so that family might have said yes anyway, even if they hadn't registered. And so the question is, it's hard to know what's the chicken and the egg in that, and it's hard to know what the actual impact. I think that registries are important. I think they get it's one of the most, it's clearly one of the ways that the general public interacts with the system most directly. I mean, that's all the publicity drives to get people to register. That's how they know about donation in general. But I do wonder if, you know, we're preaching to the converted, I guess, because those are people who would have said yes at the bedside, even without a registry. It's hard to, those studies and the impact is hard to know. I don't know, Claire, or if you have something to add on that.
Yeah, it's a really interesting question. It's something that we talk about quite often. We had an opt-in organ donor registry in the UK. When Wales moved to opt-out, we had a combined, so you could use the organ donor register to both opt in for organ donation or to opt out of organ donation. So we now have a mix. If I was starting from scratch, is that where I would put all my time and effort and resources? I just don't know. But we do know that the difference in consent rate if somebody's on the organ donor register versus if they haven't recorded a decision on the organ donor register. So I think I probably would. But there's a big debate about where the value of it, and would you just have an opt-out donor registry and on the basis that everybody else is in unless you've recorded an opt-out decision. So again, if I was forced off the fence, I would still keep the organ donor register and keep it as the opt-in and opt-out, because then it's very, very clear that it's people's choice, and it's very clear how you can record that choice.
Yeah, and I think, Matt, it is kind of chicken and egg at the same time for the way the campaigns go, because it's almost never just sign up. It's always sign up and talk to your family. It's always a combined message, right? So
it should be, yeah, 100%.
Really good points. We're just about out of time here, but I'd like to give Linda Powell an opportunity to make a comment or ask a question for the speakers.
Thanks, Nick. I'd just like to comment on the contribution to advocacy that this incredible work has done. Basically, it's a textbook of how to and the opportunity to improve and refine systems. And as you know, in Alberta, we were very involved with changes to legislation over the past 2 years. And certainly the output from the forum and the collaboration with CDTRP with creating the fast facts, those pieces of information were instrumental in leveraging change through an amendment act here in Alberta. So when we talk about education of system education, professional education, provider education, and also political education, public education, this piece of work is going to be instrumental in helping leverage those conversations. And I guess the question and the actions forward is how do we do that? How do we leverage and communicate this to get it out there and help leverage future change as well?
Thanks for that great comment. Now, it is 2:01, but if you'd like, we could stay on the call for a few more minutes to address further questions, or if we have to run, please feel free to shut it down, Matt and Claire.
I'm good. Yeah.
I see a thoughtful question in the chat here, so I'll just say anybody who has to go, thank you very much for coming, and any follow-up questions can be directed to CDTRP. So Rosalie has a question here. Feel free to speak up, Rosalie, if you'd like, but I'll start reading it on your behalf. So with the rise of AI and machine learning, and considering the concerns surrounding consent, patient privacy, and confidentiality, how do you perceive the role of an AI-based platform in facilitating the organ allocation process? Additionally, what are the significant legal and regulatory concerns that need to be addressed to ensure compliance and protect the rights of individuals participating in such a platform? Machine learning, AI. Start by explaining.
It's a nice, easy one to end on.
Well, yeah, as a worldwide AI expert, Claire, I'll let you take that one. No, I'm kidding. Obviously, neither of us are machine learning experts, but I do think that the question is well placed, and I think there are some issues that get into the governance of the OTDT system within the broader legal structure. So, and what I mean by that is, in the same way that, that you want to keep, say, systematic bias out of, that might include racial prejudices that are not meant to be baked into an algorithm around something like parole hearings, or around eligibility for a home loan. These are all examples that, I as a layperson have heard about in the lay press. Like I said, I'm far from an expert, but if you were going to design laws to protect people from racial or a systemic bias in those settings, I think you need to obviously include that potential for bias to be protections built into your organ allocation systems. Because, for example, if you have, because of historic inadequate access to healthcare, if us in Canada, we've had our First Nations populations have had historically worse outcomes in their post-transplant course. Well, if a machine sees that, it might say, well, we shouldn't allocate organs to First Nations people. Makes sense. We want the organs to last the longest. Obviously, that would be a horrific outcome, both ethically and legally and morally. And so, I agree that we need to make sure that any protections that are built in general to protect us from the machines taking over in a immoral way, we need to build those protections into these systems as well. I don't know, Claire, if you have anything else to say on that.
Yeah, I agree completely. But I do think that I will caveat it, I am not an AI expert, but I think it is actually an important factor to remove some of the biases. Obviously, you have to sense check when you're developing the allocation systems, you have to make sure, you have to run the models to make sure that you would get the outcomes that wouldn't, for whatever these sort of perverse reasons that you've put into your presumptions in the system, would lead to outcomes such as Matt talked about. But also, I think the benefit is that it takes away the bias in terms of, well, you've got somebody and, I wanted to go to my patient. He's not, maybe, it's the second in line. He's not the first in line, he's the second in line, and they're closer. So it takes some of that maybe actual or perceived bias out of the system as well, which is you have a safe, fair, equitable system for who deserve, on what basis organs should be allocated, and the machine runs it. And then you take the human bias out of the system, but that's reliant on you having human interaction and discussion in the first place. And I think in terms of the legal and regulatory concerns that need to be addressed, I talked about the need for the regulations and the guidance throughout my presentation, and is incredibly important, and it needs to cover any allocation system and any AI-based systems, as well as consent, as well as the clinical guidance and so on.
Fantastic. For non-experts, you guys have good things to say about AI. So
doesn't stop us from having views.
Yeah, well, not yet anyway. With there'll be no point being an expert in anything. Within 10 years, AI will be the expert. Just kidding, hope not. So we'll wrap it up there. Thanks for everyone for staying a little bit longer. It was a really engaging discussion. I just saw that Katie posted in the chat there that there will be a session on AI and machine learning and organ donation at the upcoming CDTRP PFD forum on June 9th, and she's posted the link. And David Hartel rightly points out that we have existing biases in the OTDC system already that need to be addressed, ideally before AI takes over. I want to thank everybody for coming. Thanks for the questions and comments throughout today's presentations. Dr. Weiss and Dr. Williment, on behalf of CDTRP, thank you again for presenting. And if anyone has any additional comments, questions, or they'd like to suggest future topics and speakers, such as myself, please contact Erica Croft at ekcroft@cdtrp.ca, and I posted that in the box. So thanks everyone for coming, and enjoy the rest of your day.
Thanks for the opportunity, guys.
Bye-bye.